My name is Sara Tolaney. I'm a breast medical oncologist at Dana-Farber Cancer Institute. So at ESMO this year, I think we've seen some exciting studies report. One of them was the overall survival data that was presented from TROPiCS-02. This was a phase 3 study that compared sacituzumab to chemotherapy of choice in very pretreated metastatic hormone receptor positive breast cancer patients. And we had already seen the progression-free survival data where we knew it was positive, although the benefits were somewhat modest in terms of the difference between the two arms. But now we're seeing that in TROPiCS-02, there was a survival benefit favoring sacituzumab over chemotherapy with about a 3-month difference in terms of overall survival. And so I think that is a clinically meaningful difference, and I think, would be a nice treatment for our patients who have pretreated ER-positive breast cancer. I think another really exciting study that was presented at ESMO was the overall survival data that came out from MONARCH 3. There's been so much controversy about what the ideal CDK4/6 inhibitor is to choose for first-line treatment of metastatic ER-positive HER2-negative disease, particularly after the ASCO presentation where we saw that PALOMA-2 did not meet OS endpoint, whereas we have seen positive survival data from ribociclib. So we've all been very eagerly awaiting survival data from the first-line abemaciclib trial with the MONARCH 3 data. And so what we saw were the second interim analysis of MONARCH 3, which, while not statistically significant for overall survival yet at this time point, did suggest almost a 13-month difference in overall survival favoring abemaciclib. And so to me, this is very clinically meaningful. I think it leaves us with the conundrum of what's the ideal CDK4/6 inhibitor to choose when picking one for our upfront patients. And I don't think there's necessarily a right option. I think at this point in time, the only agent that technically has a statistically significant improvement in survival is ribociclib. But I think the data that we're seeing with abemaciclib is very reassuring, and I think likely will meet a significant OS, hopefully with the next analysis. And so I think we have choice. Certainly palbociclib is very well tolerated, but I think it is a discussion with the patient given that there wasn't technically a survival benefit seen with that agent.